And I'm pleased to introduce Dr. Packer from Mayo Clinic to start his talk, which will be epicardial VT, no, not epicardial VT ablation. I think it is a role of left ventricular assist device in VT ablation. We're getting very complex there. So, thanks.
Well, thank you very much. I know that I look like Andrea Natali, but I know Andrea Natali, and I'm not any Andrea Natali. If we had a beauty pageant, even when we were babies, he would have won it, hands down. And if we had a beauty pageant right now, he'd still win it. I've been switched forward because I needed to catch a flight. I need to go see my dear sweet mother, and she's having some problems, and DJ was kind enough to allow this to be swapped out just a little bit. And so if you just forgive my Andrea Natali envy and just with the talk on supporting hemodynamic sorts of situations when you're doing VT ablations, and then think about that as you hear everything that's said about VT ablation as it goes along. So my disclosures have not changed at all. So the problem. Well, so this is a group of patients that we had hemodynamically unstable VTs. There were 96 different VTs, and if you look at them, there are a fair number of them that were simply hemodynamically unstable that could be induced. And that doesn't even count the ones we couldn't induce. And so that's 70%. And so what do you do with them? Well, we did the best that we could, and we did substrate-mediated approaches, and we were able to induce many more than we otherwise would have had, and we were able to eliminate them by substrate approaches. So you have that problem, and some are unstable, and some you can get with substrate, and some you can't. So what do you do? Just put in an ICD? Well, you've probably already done that. Refer them elsewhere for ablation, perhaps. Use high-pressure support when they're unstable. You can do that for a certain amount of time. I did one a couple of days ago, and by the time we were through, the 30% ejection fraction was 10%. And that's not a whole lot of fun. Go after the clinical VT only. Map really fast. You know, don't let the fellows touch the catheter and just move it around just real fast. You can do that. Pace mapping only, you can certainly do that. If you have a 12 lead of the VT, and the problem with that is they've had a device, so all you have is the leads, the electrograms from the device. Or do you do detailed substrate mapping? We do in balloon pump protocols are certainly possible. Long time ago, but there are a number of different assist devices. For those of you who know about these, you know about balloon pumps, putting them in and getting counter pulsation and really after load reduction. Rotary pump, this is like the tandem heart. You put one withdrawal catheter into the left atrium and you put it back in through the femoral artery. Microaxial, 50,000 revolutions per minute, used to give us about 2.5 liters per minute, now it can give us 5. That pulls it out of an inlet area in the left ventricle and puts it back in across the aortic valve. Really important that you know where those 2 points are. And then ECMO. ECMO pulls it out of the left atrium, or the right atrium, and puts it back in through the aorta. And it does a pretty darn good job of oxygenation. And a surprisingly good job of pumping, even though I don't really know that I like to call it a pump. So this is the first tandem heart device that we did. And you can see that we had VT, and we had no pressure whatsoever. We put in the tandem heart system, and that's a huge catheter. If you look at that, 21 French cannula into the left atrium, 17 French to the left femoral artery. And Paul and Sam did this, and it was fairly interesting. At the end of the day, we had hemodynamic support, fairly good mean blood pressure. And at the end of the day, we were able to deal with that one. So we can, but should we? And I suspect that if we ask around here, the people who do the most VT ablations probably use these the least. Is that true, Andrea? It's probably true with us. I know it's true with Bill Stevenson. Whenever I talk with Dave Wilbur about it, he has this little seizure diathesis thing that he does. But I just want to talk about this and see if we're doing this the right way. So I think there's some lessons that can be learned from VADs and people who have VT and VF. You know, if you use a VAD, and you use a rotary pump from the LA to the femoral artery, kind of a tandem heart, here's one of the first studies that was done, and it increases the cardiac index, or the power index, it increases blood pressure, and it drops the wedge. So we know pumps work. I mean, everybody who's been using different kinds of devices, bypass pumps since the early 50s, know that it works for hemodynamic support, even if people are in cardiogenic shock. And that's where the earliest amount of information was from. Here's intra-aortic balloon pump, and it's a study that looked against the rotary PLVAD, as I call them, in patients with acute myocardial infarction. Again, that's where the data is of greatest plenitude. If you look at study designs, they randomized 21 patients in each group, and you see cardiac power goes up, but the outcome wasn't all that different. And I think one of the things we need with all of this is we need more randomized studies that show, in fact, that there are different outcomes. And it can't just be it takes a shorter period of time or you use less fluoroscopy. It has to be mortality, cost, and quality of life. And that's what's lacking all the way across here, but I know that the companies that make these are working on that. Well, here's Protect 1. This is microaxial, it's 2.5 liters per minute. You can see all of the patients that were in it, and they actually did pretty well. There were a couple of deaths, but overall, for patients who had high-risk infarctions, they were undergoing PCI, temporized quite nicely, and they were able to accomplish what they needed to. Well, back just a little bit, if you look at the database for the microaxial flow support in 251 patients, most of them were used electively for PCIs. Some were used for anterior myocardial infarction or acute myocardial infarction and shock, other forms of shock. I don't know what other forms of shock are. You know, this is acute MI shock, and this just must be flat-out bad shock. And then urgent applications, because you were doing okay until you dilated that left main by accident, and all of a sudden you've got much more of a problem than you think. So let's learn something from LVADs. Here are the typical LVADs, and you put them in and bring them out someplace. I think all of us, how many of you have done VT ablations on LVAD patients? A bunch of us. You know, we see about one of these every 2 weeks. We don't like the way that the surgeons put them in. We want them to do more to deal with the tissue right around the inflow into the system and then output into the aorta. Again, you can do them in a variety of different ways. And they're no longer for breakfast anymore. They're for destination therapy. And if you look at patients with VT, there really were not that many patients with VT. Here's one patient. These are 4 different studies. 1 patient, 2 patients, 2 patients, 1 patient that did very, very well through treatment with an LVAD for their VT. This is looking at the obvious issue, and that's in patients who have those kind of continuous flow devices or LVADs. How many of them are going to get VT or VF long term? And this is just one study from Anderson, and about 52% of them do. And so we learn that something has to be designed up front to deal with that risk. If you look at a number of different studies together, then the risk is someplace between about 20% and 60%. That patients who have an LVAD will get a ventricular arrhythmia. Now, I suspect most of us implant defibrillators in these patients, but they still come back with multiple shocks and they still have to be ablated, and most of the time the ones that we deal with, it has something to do with the inlet, and intracardiac ultrasound is very, very helpful. So the pumps by themselves are not foolproof. The arrhythmias kind of live on lives of their own. Now, this is looking at improved survival if you put an ICD in LVAD patients, and you can see the patient characteristics and the ICD outcomes. I'm just going to show you this. The survival is better than it is if you don't do it. And I think that most people everywhere put the device in first, and then we get to them when they have recurrent ventricular tachycardia after the fact. Well, here are 3 patients, kind of the first 3, that underwent VT ablation in the setting of a percutaneous LVAD device. John Miller did these. Difficult patients, low hemodynamic outputs, really shocky to begin with. One did very well, one died from an infection, and one had recurrent VT. They had none of the clinical VT, and after that had significant problems. Well, that was the first time through. And so it's going to be hard. Well, when should we use these then? Given that as a background, I think it depends on the spectrum of the VT and VF and the stability of the system. And I like to look at it this way. I think the application of hemodynamic support devices is the rationale for using it. The indication for support goes up as you go through different kinds of arrhythmias. If you've got stable monomorphic VT or multiple VTs, but they're stable, you can get those with VT activation mapping or entrainment or pace mapping or voltage or even ice mapping or localized ablation. And so I think that these are kind of the gold cards when you get on a plane. You still have to pay for your bags. You still have to go to the effort. But at the end of the day, things work out pretty well for those VTs. If you look at this a little bit further, here's one, I just random sample. It turned out that this guy had 11 different VTs. This was VT number 11. I had already gotten rid of the 10 hemodynamic unstable VTs, and I'll tell you about that in a minute. But we were able to do entrainment mapping, and the PPI was exactly the same as the VT cycle length. We ablated that and got rid of it. And so this is one that works quite nicely. Now, sometimes you have unstable VTs with stable substrate. And if you look at stable substrate, then you can deal with that substrate by voltage mapping. We use strain rate imaging from an ultrasound system, or MR, and looking at where the tissue abnormalities are, and then guiding according to that. And maybe you can get unstable VTs with unstable substrates. Normal sinus rhythm voltage mapping, pace mapping, substrate imaging, 12-lead Holters, and linear looking for channel kind of ablation. And then if you're me, what you do with it is you do border homogenization. If you're Andrea Natali, you homogenize the entire substrate. I don't know which one is best, but I found out that all these patients, we did border homogenization, and you can see how many had inducible VTs, 17 patients, and we only had a smattering of VTs, and if you look at how they occurred, then these patients had reasonably sharp demarcation between scar and relatively normal tissue. And we suck in the voltage map. So we go from 0.25 to 1, rather than trying to go to 1.5 or 2.5, because it forces you to suck in your ablation site to within the scar margin. And then we simply do border homogenization. Now, we do pick out what's going on with channels that we might happen to see, but the more important issue is the border homogenization. And with that, it's so common for people after the procedure to have much in the way of ICD shocks. Sometimes they do. You know, they change things, or we didn't get something, or we have to do it a second time, and if we do that, then they do reasonably well. So what about supporting VT mapping and ablation where substrate mapping simply isn't enough? Well, there's the approach that Sam Asser-Vatham used with the microaxial blood pump, and he did about 15 patients. Put it in, again, it's very important where you get your intake in the LV and your output back into the aorta, and you need to make sure that you're well across that aortic valve. He did that. In this first report, it was 3 patients, and they were unstable. Again, if you move this too much one way or the other, then you can lose the flow. And this is back in the days of the 2.5 flow. We use ultrasound a lot to tell us what's going on. Second patient had idiopathic dilated cardiomyopathy, and he mapped out, but every time we tried to induce him, then he dropped his pressure. With the system, then we were able to get enough so that we could map. And actually, it worked out very, very well. Well, back when I looked at this initially, there had been the first 76 cases. You can see why they were ablated. Orlando Regional had done 15, Texas Heart 15. We had done 13, and Mount Sinai had done 10. and the outcomes were fairly reasonable. But the question is, do you get something that you couldn't get simply by doing substrate mapping? So these are the silvers now back here. These are the gold cards. They've moved up a little bit. Maybe it's a little bit more important to do those sorts of things. And then there's those that just flat out need hemodynamic support, unstable VT and unstable substrate, and PVCs that induce VF. This is one of Michelle Hessegare's VF cases. And if every time you see one of the offending PVCs, they go into VF, that's naughty. You have to put them in timeout, and sometimes you have to put in devices that will support their pressure while you're doing the work. Or Brugada syndrome is a fairly common one, especially if you're doing the Wee-Nudmani carpet bombing approach to the RV outflow tract. And in some of the patients that we've done where we've seen that you just turn on the power, you have polymorphic VT to begin with, you just turn on the power and you get polymorphic VT or VF. I call that electrophysiologic chicken, because you have to hold your thumb on the button to get you through the time and through the tissue to allow you to ablate that particular arrhythmia. And this is what happened with that patient. This is the heart rate before the patient had hundreds and hundreds of episodes of PVCs and couplets and non-sustained VT. This is one of Peng Chen's, ablating near the pulmonary or the papillary muscle. Papillary muscles, I think, are a little bit problematic. You burn there, and about every time you do, they do some kind of polymorphic VT or sometimes ventricular fibrillation, so perhaps that. Well, there's a paper that is just out earlier this year. This is from Mark Miller and Vivek Reddy and his cast of thousands in between. And if you look here, then they got very, very good support, allowing them to have appropriate mean pressures. They dropped a little bit when they went into VT, but they were able to use more conventional entrainment mapping and eliminate the tachycardia with well-formed substrate, but with support from the spinner device. One thing he said and has pointed out that cerebral oximetry monitoring is really, really important. And you can see the mean duration of the ventricular tachycardia episodes. They were able to do more for longer if they had that support. And the total duration of VT was longer if they had that kind of criteria met. There's other ways you can do it. You can do it with the ECMO system. And this is from Peter Neusel, his group, and Andrea Natali is part of that one also. And they made comparisons of ECMO versus rotator, and in this case, rotator from the LV input to the aortic output, and then the tandem heart in between. And you can see that the ECMO actually did significantly better from the standpoint of maintaining pressure and overall capability of ongoing pump. Here again, they threw in some norepinephrine to see what that did. And norepinephrine improved if you only have a 2.5 liter output. All these numbers will likely change with 5 liter outputs. But you can see differences in some of the advantages perhaps with an ECMO system. And these are his overall data that I won't go through. One more, this is from Dave Bendett's group and Lou, and they used Impella for some, and in some they just flat out did this peripheral bypass. And you can do that, but that takes a fair amount of work with peripheral bypass, but they were able to ablate and do a fair amount of entrainment and mapping and had very, very good pressures in supporting, but you'd expect that from actual bypass pumps. One thing they did do, though, is they looked at the utility of that kind of approach on oxygenation and on lactate formation. This paper is not quite out, but I think that it does a very nice job of giving you secondary endpoints or measures for deciding just how good you are in what you're doing. So you can use the silver card, the gold card, or the platinum plus card. I think platinum plus is the hemodynamic support in these patients. I simply don't think you need it for these, but I think that it's very useful there. But there are some final considerations. Number one, if you've got an unstable VT, treat the underlying disease. Tune them up, cool them off, and let antiarrhythmic drug help. Another thing is quiet the storm with assist devices if you need to. We maybe underuse them in quieting patients down in CCUs. But then the most important is understand the substrate, establish goals for ablation, determine where to focus mapping, make sure equipment and personnel are ready, use the 3D mapping system, use pace mapping and entrainment correctly, don't miss serendipitous findings. If VT isn't eliminated where you are, go someplace else. Contact, 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 and more power isn't necessarily better. One final thing. Hemodynamic support does not compensate for the lack of an understanding of 1 through 10. Anybody who thinks you can put in some kind of an ancillary pump and it's going to absolve you of understanding all the first principles of electrophysiology, you're in big trouble. So I'm going to end with this. I ended with this last time too. If I can have you turn the volume way up, you have to be careful that you don't try too hard because it can create some problems. And if you look at it enough, you might understand it a little bit better, but you get tempted when you're dealing with these kinds of VTs to whack at it. Whack it again and again. Throw in another pump. Hit it again. Hit it again. Put in more pumps. Put in bigger lesion makers. We're using carbon beam. Hit it again. Sometimes, though, you need to stand back and think about what you're doing so that you do a good job, because if you don't, you might get yourself into some degree of trouble. So step back and think about it. And just take it from there. So again, I appreciate being here. I appreciate the opportunity. Thank you so much for changing the schedule, and hopefully that's of some interest.